Hey there, and welcome back to the deep dive. Really glad you could join us. You know, our setup here, we take the source material you send over, your notes, research, whatever it is, and we jump right in. Our aim is always to pull out the absolute key, high-yield stuff for you, cut through the noise, basically. Today, we've got this great set of revision notes focusing on a very specific but really, really important topic in ear health, cholesteatoma. And since this is clearly revision material, maybe for something like the MSRA, our mission today feels pretty straightforward.
Absolutely. Cholesteatoma, it's one of those conditions you really have to get your head around for otological practice.
Yes.
It's common enough, yes, but also the potential complications, they can be quite significant. So understanding it properly, especially from structured notes like these, is key.
Exactly. So our mission for this deep dive, unpack these cholesteatoma notes. We want to pull out all the high-yield info you need for understanding it and, crucially, for remembering it during revision. We'll just follow the path laid out right here in the notes definition, causes, all the way through to what can go wrong.
And we'll try and, weave the concepts together, connect the dots between different sections, maybe clarify some trickier points, all based strictly on what's in this source material you've shared.
Okay, then let's dive in, starting right at the beginning. The absolute basics. What is cholesteatoma according to these notes? What are we actually discussing?
Right, looking here, the definition is, well, it's pretty clear. It's a non-cancerous growth, forms in the middle ear. The fundamental issue is this abnormal buildup of squamous epithelium, basically skin cells.
Skin cells.
Yeah, regular skin cells, but where they shouldn't be in the middle ear. And they form this kind of sac.
Okay, skin cells, wrong place, forming a sac. Got it. That really clarifies the basic problem. Now, the notes jump straight into classification. What are the main types we need to know?
These notes list two main categories you need to keep separate: congenital and acquired. Congenital first, it's rare. The material says only about 2% of cases. It happens because some squamous epithelium gets trapped during early development, embryogenesis.
Trapped during development. Okay.
Yeah. And it might not cause symptoms initially, but can lead to conductive hearing loss.
Okay, so congenital is uncommon, something you're born with because of how things developed. That means most cases are acquired.
Exactly. Acquired cholesteatoma is much more common, around 80% of cases based on these notes, and it's directly linked to long-term ear problems. The notes then split acquired into two types: primary and secondary.
Ah, okay, the acquired subtypes. Let's break that down. Primary, acquired. What's the mechanism there according to the notes?
So the material links primary acquired directly to eustachian tube dysfunction. That tube isn't working right. This causes negative pressure in the middle ear, which sucks the tympanic membrane inwards.
Sucks it in.
Yeah, especially the upper, more flexible part, the pars flaccida. Over time, this forms what's called a retraction pocket. And it's in that pocket that the skin cells, the squamous epithelium, get trapped and start to build up.
Right, so primary is like the eardrum collapsing inwards because of pressure issues, making a little trap for skin cells, makes sense. And secondary acquired, how does that happen?
Secondary acquire, as it's described here, happens because of actual damage or insults to the eardrum itself. So think trauma, or maybe more commonly, perforations, holes from things like recurrent ear infections, otitis media.
Right.
In those situations, the skin cells can basically just grow directly into the middle ear space through that hole or tear or get implanted there.
Got it. So that distinction is really key for revision, isn't it? Primary via the retraction pocket, secondary via direct entry through damage. And these notes also show how cholesteatoma fits into the bigger picture of ear problems, the whole otitis media thing.
Yes, they do. The material positions cholesteatoma as one specific type within that whole spectrum of otitis media conditions. Alongside things like acute otitis media, that's sudden infection, or OME, otitis media with effusion, glue ear,
right,
and chronic suppurative otitis media, CSOM, the chronic infection with discharge, and mastoiditis, the bone infection. Cholesteatoma stands out because it's specifically defined by having that skin present in the middle ear, often resulting from those chronic changes, especially that eardrum retraction.
So it's part of that family, but the key difference is that abnormal skin growth. That feels like a really high yield point to remember. Okay, moving on. The notes get into why this happens, the etiology and the pathophysiology. So how does someone actually get this? The material says the exact cause isn't fully understood.
Exactly, yeah. The etiology seems to be, well, multifactorial. That's the term used here. It's probably a combination of things. Chronic middle ear infections are a big one. That eustachian tube dysfunction we mentioned.
Okay.
Maybe some underlying congenital abnormalities that make someone prone to it. And also previous ear surgery or trauma.
That multifactorial idea seems important. And that connects directly to the risk factors listed here. Based on these notes, what specific things make someone more likely to develop it?
Right. The notes list several key risk factors you should be aware of. A history of recurrent ear infections or ones that weren't treated properly that make sense given the link to otitis media. Chronic eustachian tube dysfunction is listed again, tied directly to that primary acquired type. Certain congenital middle ear issues, and they specifically mention congenital cleft palate here as a risk factor.
Oh, interesting.
And finally, any history of ear surgery or trauma. That includes accidental injury, but also surgical stuff like having grommets put in. That's noted as increasing the risk.
Okay, so it really boils down to a history of ear trouble, right?
Yeah.
Poor tube function, maybe developmental factors or previous interventions. That seems to be the pattern. Now, pathophysiology, the how it actually works, how does that sac form, and crucially, why does it cause problems?
This is where it gets, well, really interesting biologically. The notes describe the core process as this abnormal migration and buildup of those squamous epithelial cells, skin cells. Remember, they belong in the ear canal normally, but here they migrate into the middle ear space, often starting from that retraction pocket or through a perforation.
And this collection of skin cells just keeps accumulating, builds up into that sac.
Exactly, that buildup forms the cholesteatoma sac. But, and this is critical, it's not like some harmless cyst that just sits there. These notes really emphasize that this growth is actively erosive.
Destructive.
Destructive. Okay, what exactly does it erode, and why is that so bad?
Well, as the stapes grows, the cells inside shed keratin, like normal skin, but they also release enzymes, destructive enzymes. And according to these notes, it's these processes that lead to the erosion, the dissolving of the nearby bone structures.
Wow.
They specifically point out erosion of the ossicles, the tiny malleus and pertus stapes bones needed for hearing. That causes the hearing loss.
Right.
It can also eat into the mastoid bone behind the ear and even push into the inner ear structures, the cochlear and balance organs.
So it's not just occupying space, it's actively dissolving the delicate machinery around it. That really explains why it can lead to such varied and serious issues. Remembering that mechanism helps understand the potential consequences. Before we talk about symptoms, what else might look like this? These notes give some differential diagnoses. Yeah, that's a really important clinical point, isn't it? When you see certain ear symptoms, you can't just jump to cholesteatoma. You need to consider other things. The notes list several possibilities here. Otitis media with effusion that's fluid, not skin. Otitis externa infection of the outer ear canal.
Okay.
Tympanosclerosis, that's scarring or calcification. Osteonecrosis of the ear canal bone, death there. Actual middle ear tumors, which are rare but serious. And other kinds of cysts. Ruling these out is a key step.
Good to keep those alternatives in mind. Okay, switching gears slightly, epidemiology. How common is this, and who, according to this material, tends to get it?
Looking at the figures presented here, the UK prevalence is estimated around 9 per 100,000 people each year. The note suggests it's a bit more common in men and also in individuals from lower income backgrounds. And no surprise, given what we've discussed, it's often diagnosed in people who have that history of chronic ear infections.
Right.
And here's a high-yield point from the notes. Cholesteatoma is highlighted as one of the most common reasons people end up needing ear surgery.
That is a significant point, common enough to be a major driver for surgery. So how does it typically present? Are the symptoms the same for everyone?
The notes give a pretty good breakdown, and they distinguish between the types again. Congenital ones, remember, they're rare, often found by chance in young kids, maybe 6 months to 5 years old. Often there's no history of ear trouble. If the lesion is large, it might present with conductive hearing loss.
Found incidentally, okay. And the more common acquired type?
Acquired cholesteatomas, well, they often present with what the notes describe as a classic symptom. Painless but foul-smelling ear discharge, otorrhea. That's a really key feature to watch for.
Foul-smelling discharge, painless, got it.
Other common things mentioned here. Recurrent ear infections that just don't seem to clear up properly with antibiotics. Unilateral conductive hearing loss in just one ear. And then on examination, the notes say you should look for that eardrum perforation, or critically, that retraction pocket we talked about. You might even see pus or granulation tissue in the ear canal.
Okay. And the general list of symptoms covering the range of possibilities.
Yeah, the notes list the common ones, that chronic ear drainage, otorrhea, the hearing loss, the recurrent infections, sometimes ear pain, though often painless initially, tinnitus ringing in the ears, dizziness, and sometimes just a feeling of pressure or fullness in the ear.
That's quite a list. And things like dizziness or facial weakness would suggest it's getting deeper, right? Affecting more critical structures. The notes mention some even more serious possibilities.
They do. As the cholesteatoma grows and erodes bone, you can get additional features. Vertigo, a real spinning sensation, facial nerve palsy weakness, or paralysis on one side of the face if it affects the facial nerve. And in really advanced cases, the notes even mention cerebellopontine angle syndrome, problems near the brainstem due to extensive erosion.
Wow.
And the notes really stress that the symptoms depend on the size and location. Small ones might just cause that conductive hearing loss by messing with the ossicles. But larger ones, as they erode more widely, that's when you see the vertigo, headaches, facial nerve issues.
And infection makes it worse.
Definitely. If it gets infected, these notes warn it can lead to really serious, even life-threatening complications. Things like meningitis or a brain abscess because the infection can spread through the eroded bone into the central nervous system, or even a neck abscess. They also point out it can sometimes just occur in the ear canal itself, not necessarily deep in the middle ear.
That progression from just hearing loss to potentially fatal complications really underscores why early diagnosis is so critical. It's a good reminder that even just ongoing ear discharge needs a proper look. Okay, so if the symptoms and the look of the ear raise suspicion, how do you confirm it's cholesteatoma and figure out how bad it is? What do the notes say about investigations?
Right, the diagnostic process starts with that careful look in the ear otoscopy. And the notes specifically highlight looking for the attic crust. That's a classic sign described here, a buildup of keratin debris, often in a retraction pocket in that upper part of the eardrum, a pars flaccida. Seeing that is highly suggestive.
The attic crust.
But just looking isn't enough to see the full extent, especially bony erosion. So these notes state that CT imaging is essential.
CT scan. Why CT?
CT is brilliant for showing bone detail, so it can reveal exactly how much erosion there is, which bones are affected, how far it's spread within the mastoid, if there's worry about it pushing into soft tissues or involving nerves or blood vessels nearby. The notes say MRI might be added too. MRI is better for soft tissue detail. And this imaging, the notes are clear, is absolutely crucial for planning the surgery properly.
Makes perfect sense. You need that detailed map before you go in. Which brings us neatly to management. The notes seem pretty definite about the main strategy here.
Oh, absolutely. The source material is unambiguous. Surgical removal is the primary treatment. It's the only definitive way to deal with it. The goals of the surgery, as listed right here, are several things. First, get rid of all the cholesteatoma. Second, repair any damage it caused to the middle ear structures like the eardrum or ossicles. And third, try to keep or even improve the patient's hearing.
And antibiotics.
Antibiotics might be used, yeah, but mainly to treat any active infection before surgery, or maybe prevent infection afterwards. Words of the cholesteatoma itself, the notes are clear on that. Only surgery does.
Okay, so surgery is the main event, and these notes describe different surgical approaches, don't they? What are the main options?
Yes, the material outlines the main surgical techniques. There's the open technique, often called a tympanomastoidectomy. This involves removing quite a bit of the mastoid bone behind the ear, creating an open mastoid cavity that connects to the ear canal.
An open cavity, why?
The idea as described here is that it makes it easier for the surgeon to be absolutely sure they've removed all the disease, especially if it's extensive. The notes say it's very successful at clearing the cholesteatoma. The downside, it leaves a larger ear canal opening, that mastoid cavity, which needs lifelong, regular cleaning by a specialist to stop debris and wax building up and causing problems.
Okay, so open technique. Good clearance, especially for bad cases, but means a permanent cavity needing regular care. What's the alternative mentioned?
The alternative is the closed technique. Sometimes this is done along with a tympanoplasty to repair the eardrum. With this approach, the surgeon tries to preserve the back wall of the ear canal, avoiding that large open cavity.
Ah, so cosmetically better, less ongoing cleaning.
Generally, yes. Better cosmetic results, no need for that regular cavity cleaning. But the notes state clearly, the closed technique has a higher risk that some disease gets left behind, or that it comes back later. Recurrence is more likely.
Higher recurrence risk.
Yeah, and because of that higher risk, the notes say it often requires a planned second-look operation, maybe 6 to 12 months later, just to go back in and check for any regrowth and remove it if necessary.
I see.
The notes also give a brief mention to autoendoscopy using tiny cameras through the ear canal as sort of an evolving technique that's being explored more.
So it's a real trade-off then. Certainty of clearance with the open technique versus preserving more normal anatomy with the closed technique, but with that higher recurrence risk possibly needing a second look. What if someone just can't have surgery for some reason?
The notes touch on that possibility, but briefly. If surgery isn't an option, Then really careful, regular ear cleaning by someone experienced, plus aggressively treating any infections might be recommended. And the notes really stress these non-surgical things will not stop the cholesteatoma from growing. They don't halt the underlying erosive process.
Right.
The main goals you're aiming for with surgery, according to this material, are really about eliminating the disease and stopping those complications, letting people get back to normal activities, preserving or improving hearing if possible, and minimizing that risk of it coming back.
Looking ahead then, what's a prognosis usually like for someone with cholesteatoma based on these notes after they've had treatment?
Well, the notes state pretty clearly that the prognosis really depends on a few things. How far the disease had progressed when it was treated is a big factor. Also, whether any complications had already happened before surgery, and of course how successful the surgery was at getting all the cholesteatoma out. But overall, with the right treatment done in time, the prognosis is generally described here as favorable.
Favorable is good news, but these notes definitely seem to imply it's not always a one-and-done fix. Recurrence sounds like a big theme.
That's absolutely right. Recurrence is a definite possibility, and the notes really underline that long-term follow-up after surgery is essential. You can't just assume it's gone forever. The material even gives some figures the risk of residual disease, meaning some was left behind, or recurrent disease, meaning it grew back, can range from 5% up to maybe 30%, depending on the initial extent and the surgical technique used.
Wow, up to 30%?
Yeah, and another really important point for revision mentioned here. About 7% to 10% of patients might eventually develop a cholesteatoma in the other ear.
Oh, really?
Yeah, so regular checks of both ears are important long term.
So even after successful surgery on one side, you've got to stay vigilant for it coming back there and potentially showing up on the other side. Okay. And finally, the notes wrap up with potential complications. What can go wrong if it's not treated, or sometimes even as a result of the treatment?
What's quite striking here is just how much damage this technically non-cancerous growth can cause if you just leave it. The notes list some really significant complications from that ongoing bone erosion. Permanent hearing loss, definitely if the inner ear ossicles get too damaged. Chronic balance problems or dizziness. Facial nerve paralysis, if that nerve canal gets eroded, that's obviously devastating.
Yeah.
And then the really critical ones. Severe, potentially life-threatening infections like meningitis or even a brain abscess. That happens if the erosion breaks through the bone, separating the ear structures from the brain cavity. The notes also mention erosion into other nearby structures.
Those CNS complications are terrifying, really drives home the seriousness. But unfortunately, the surgery itself, the treatment, also carries risks, as outlined here.
It's true, yeah. Necessary but not risk-free. The notes list potential complications specifically linked to the surgery. Things like temporary changes in taste. That's quite common, actually, because a small nerve often gets stretched or bruised.
Okay.
Infection of the ear cartilage, called perichondritis or chondritis. Narrowing of the ear canal, afterwards stenosis. Facial nerve injury is rare, but it's a known feared risk of ear surgery. You can also get a fistula and abnormal opening into the semicircular canals, the balance organs, which can cause persistent dizziness. Or just general injury to the inner ear, the labyrinth or middle ear, causing dizziness. And interestingly, the notes also mention that you can sometimes develop an acquired cholesteatoma later on, even after having surgery for a congenital one.
Wow. Okay, that was a really thorough unpack of these notes on cholesteatoma. It definitely makes it crystal clear that even though it's not cancer, it's a serious destructive condition that needs prompt diagnosis and usually surgery.
Indeed. And if we sort of pull back to the bigger picture, for anyone using this material for revision, like for the MSRA, really grasping those distinctions between the types, understanding that pathway from risk factors through the pathophysiology, that erosion to the symptoms, that's crucial. And understanding why surgery is the mainstay because of that erosive potential and the risk of those nasty complications. Remembering key signs like that foul-smelling discharge, the attic crust, the unilateral conductive loss, and the potential for deep erosion, those could be really helpful memory hooks.
Absolutely. It really highlights why things like chronic ear discharge or recurrent infections shouldn't just be brushed off, and why this specific condition is so important within otology.
Which does raise an interesting point to perhaps think about. Given that potential for recurrence and the complications even from surgery, what does this material implicitly tell us about the importance of really clear communication with patients about long-term follow-up and the warning signs they need to look out for after treatment? Something to mull over as you consolidate this information.
It's a great thought to end on, connecting the revision facts back to the reality of patient management. We really hope this deep dive into your source material has been useful, maybe even made revision a bit clearer for cholesteatoma. And remember, if you are revising for the MSRA or just want to explore these kinds of topics in more depth, there are great resources available. You can check out pastthemsra.com for comprehensive revision materials, and don't forget freemsra.com as well for some excellent free resources to support your learning. Okay, that's all for this deep dive. We'll catch you next time for another exploration into the fascinating source material that you share with us.